Cognitive discontrol highlights impaired impulse control. This model underscores the need for integrated treatment addressing emotional, cognitive, and behavioral components. Hello. Thank you, sir. Thank you very much. At the onset, I would like to thank organizer and scientific committee for giving me opportunity to talk on this topic, the hypersexuality spectrum, understanding and addressing excessive hypersexual behavior. Uh, Initially, I would like to tell you about what is hypersexuality. Uh, we should understand first that hypersexuality has increasingly become a significant clinical issue. Previously, it was seen through the moral lens, but now it has been diagnosed as it has been labeled as a mental health issue. I will come to that later. Uh, Hypersexuality refers to a pattern of excessive sexual thoughts, fantasies, urges, or behavior that interfere with individuals' daily functioning, personal relationships, and overall well-being. These three words are very much important. Like individuals, it should interfere with individuals' daily functioning, personal relationships, and overall well-being. It can have devastating consequences on various aspects of person's life, including work, social and interactions, and emotional health. The aim of this presentation is to discuss about the spectrum of the hypersexuality behaviors, classification challenges, and most effective treatment strategies that are available as of now. The importance of discussing this topic is that we know that because of the online platforms, more individuals are experiencing hypersexuality. Online chatting or social media apps are there, dating apps are there, and because of this, pornography is easily available at the click. So more individuals are indulging in hypersexual behavior, and this is causing a lot of problem in their personal life and social and work life. uh, Once considered private concern, today it is recognized as a mental health disorder that requires professional intervention. The digital age has made it easier for individuals to engage in compulsive sexual behaviors which can escalate quickly. If we see the history of hypersexual disorders, historically, excessive sexual behavior was seen through the moral lens. We have Greek literature which has mentioned nymphomania in women and Don Juanism in men, based on the character in one of the literary book over there. However, with advances in psychiatry, hypersexuality is now recognized as a clinical issue. Dr. Benjamin Rush, in 18th century itself, has discussed few cases, and he has mentioned about this hypersexual behavior which can cause distress to the people. Later, Kraft Ebing in 20th century laid the groundwork for understanding hypersexuality as a psychiatric concern. Dr. Patrick Kans was the one who has given us the term sexual addiction. Over time, debates about its classification in diagnostic manual like DSM have shaped our current understanding. Today, it is formally recognized as compulsive sexual behavior disorder in ICD-11. When it was decided to take in DSM-5 in 2010, when there was a body group which was working on this sexual disorder and gender identity disorder. So Dr. Martin Kafka has proposed this term, that is hypersexual disorder. But there were some issues because of which it was not included in DSM-5. The first issue was that in them or in the psychiatrist group itself, there was various groups who are saying that it can't be classified in a particular group because somewhere of the opinion that it is a compulsive behavior, someone aware of the opinion that it should be included in an addiction, and somewhere aware of the opinion that it should be included as an impulse control disorder. So because of that, it was not included. above that, there was thinking that over-pathologizing of normal sexual behavior can happen. And second thing, even though there is empirical data and few studies, there is insufficient research related to this topic. So it was not included in DSM. But as I said, it was included in ICD-11, which which is recognized as compulsive sexual behavior disorder. This was given as a criteria for hypersexual disorder. Hypersexuality is not simply high levels of sexual activity, but it is a disorder characterized by lack of control, emotional distress, and significant impairment. There are excessive sexual thoughts and behaviors. There is persistent effort to control these urges, but patient fails even after having a negative consequences. The continued behavior despite adverse consequences. And one of the criteria is that it should last for at least 6 months, and patient has to be above age 18 years. And to make the accurate diagnosis, one should rule out other factors or disorders like mania, substance use, ensuring that hypersexuality is identified as a primary condition. This was the diagnostic criteria. I will not go into the details. Coming to the prevalence and epidemiology, though exact studies and exact data is not available, it is said that the studies had said that approximately 3 to 6% of the general population are suffering from this hypersexuality disorder. The condition is more frequently seen or reported in men than in women, with men more likely to engage in behaviors like compulsive pornography use, excessive masturbation, and multiple sexual partners. In female, it was said that because of the societal stigma and many women doesn't report, so it is difficult to say now that men are more suffering than the women. Considering the age, it can occur at any age, but it typically falls in late adolescence to the early adulthood. It oftenly co-occurs with other psychiatric conditions such as depression, anxiety, and substance use disorder. As I said, there are various classification models for the hypersexuality. One is the compulsive, another is the impulsive, and the third one is the addictive. Many of you might be knowing about the compulsive disorders, obsessive compulsive disorders. So some were saying that this hypersexual behavior is to relieve the anxiety. The patient gets urges in their mind, they get thoughts in their mind, and this causes anxiety. And to relieve this anxiety, they have to compulsively act on it or behave. They have to do that hypersexual behavior. The another model is impulsive model, which compares it with the impulsive disorders like kleptomania, pathological gambling, where patient has that irresistible urge to go for that, and there is immediate gratification is needed, and when a patient gets immediate gratification after doing that act, but later they develop guilt over that. So this was the another model, and the third model was the addictive model, which views it as a behavioral addiction, where the individual feels a compulsive need for sexual gratification despite negative consequences. There is the craving, there is tolerance, and withdrawal symptoms can be seen when they does not indulge in sexual behavior. So this behavioral becomes central to the individual's life, leading to neglect of other activities and responsibilities. Understanding this model, why it is important, because as of now, as I said, there are no studies available, so we have to consider as one of these three models, and we have to treat according to these three models. And if there are other symptoms which suggest of compulsive disorder, impulse control disorder, or addictive behavior is there, then we can go along that treatment line. This one is the model, ABC model, suggested by Stein et al. A stands for affective dysregulation, B for behavioral addiction, and C for cognitive discontrol. Basically, it comes to those three models only, but here they have taken all the three criteria together. Affective dysregulation refers to using sex as a coping mechanism for negative emotions. When your patient feel depressed, when your patient feel anxious, or they feel loneliness, they will go for this hypersexual behavior. Behavioral addiction involves compulsive engagement in sexual behavior. Patient knows that they are spending excessive time. Their most of the time is spent on planning for it, acting on it, but they could not control it, and they had to go for it in spite of the negative consequences. Uh, Cognitive dyscontrol highlights impaired impulse control. This model underscores the need for integrated treatment addressing emotional, cognitive, and behavioral components. As I said, it can have devastating impact on the daily life of the patient. Hypersexuality can cause effect on personal relationship, as patients spend much of their time on watching pornography, masturbation, or trying to attempt multiple sexual partners. So there can be marital discord, or there could be poor interpersonal relationship between the people. And when they spend much more time on these activities, they can even uh, try to avoid the going into the society, and they won't have this societal relationship in the society. There could be occupational consequences. It can cause poor performance at the work. It can lead to the absenteeism. It has been found in many patients that it can lead to the absenteeism. And somewhere legal consequences are also there, like trying to behave badly at the workplace with the colleagues, or watching porn during the work hours, and that can lead to the loss of their job also. There are legal consequences, specifically in pedophilic patients, or those engage with that kind of behavior, or with go for they attempt rapes, or this kind of things. So legal consequences can be there, and financial issues, as we know that there online sex is available nowadays with a click. You have to pay for it, and you can get the partners, you can watch them, and you can masturbate, or you can indulge in sexual behavior. So this can lead to the financial issues. Now we have heard, we are hearing about the frauds. They call on the Facebook, they call on the Instagram, they try to be close friend, they will record the videos, and then they will ask for the money, or the demand for the money. So that can lead to the financial issues. Emotional and mental health impact is there. Then physical health risk, because patient lacks self-care, or they won't spend time for the self-care. And also patient can indulge in risky behaviors, so they can have HIV, AIDS, or something, some other kind of STDs. I will skip through some of the slides. It is important to look for the differential diagnosis of hypersexuality. Hypersexuality, we have to go with the systemic approach. First, we have to rule out certain medical conditions, like endocrinal conditions, where increase in the testosterone can cause excessive desire, and can cause hypersexuality. We have to rule out neurological conditions like temporal lobe epilepsy, frontal lobe tumors, or traumatic brain injuries to the frontal lobe, which can lead to the impulsive behavior in these patients. We have to also rule out substance-induced behaviors. We have to rule out mood or psychotic disorders like bipolar disorder, personality disorder like bipolar mood disorder, and paraphilic interest we have to rule out. This is important to make accurate diagnosis and the treatment. If we look into the neurobiological aspects of hypersexuality, it was said that hypersexuality involves dysfunction in the brain circuits that are related to the reward and impulse control, particularly dopaminergic system. There is one system which is called as corticostriatal thalamic system, which shows this problem, or dysfunction in the brain circuit, and which leads to the habitual behavior, impulsive behavior, and this excessive hypersexuality or hypersexual behavior. The neurological understanding is very much important because it guides the development of targeted pharmacological treatments. Psychological factors, I will just say few words. Early trauma, trauma during the childhood, emotional dysregulation, and maladaptive coping strategies are responsible for this. Personality traits which shows impulsivity and sensation seeking can have this hypersexual behavior. Cognitive distortions such as irrational beliefs about self-worth tied to sexual activity can reinforce this kind of behavior. So if we see these neurological models and psychological causes, it becomes important that we should treat at a psychological level and at a neurobiological level. That is, medications and psychotherapy both are important in these patients. To measure this hypersexuality, we usually use hypersexuality disorder screening inventory. It is based on DSM-5 and it is used for screening, and it is used for research work also nowadays. I will not go into the details. The another scale or inventory available is hypersexual behavior inventory HBI-19, because there are 19 components and individual rate their ability to control sexual urges, how often they use sex to cope with emotional distress, and the negative impact of sexual behavior on their lives. So after this, we make a diagnosis and we come to the treatment. Treatment is, as I said, combination of psychotherapy and pharmacological intervention is important. In CBT or cognitive behavioral therapy is one of the most effective approach, helping individuals to challenge their thoughts, manage triggers, and develop healthier coping mechanisms. Medications like SSRIs or dopamine antagonist may be prescribed to address the neurobiological factors driving the compulsive behavior. I will not go into the CBT in much details. So, coming to the pharmacotherapy, as I said, SSRIs like fluoxetine, sertraline, paroxetine are available, then which are typically useful in patients showing compulsive or impulsive kind of behavior. Then we have naltrexone, which has usefulness in the patient showing addictive kind of behavior. And in some studies, it has been suggested that we can also use anti-androgens in these kind of patients. But the studies are very much rare. Group-based CBT for hypersexuality is very much useful. It provides supportive environment, follows a structure format, teaching CBT techniques like cognitive restructuring, impulse control, and behavioral activation. Participants learn from each other's experience and receive peer support and accountability, which enhances motivation, because this is much important, because there is stigma related to it, and when patients see that there are other patients who are suffering from this, so they feel relieved. And the another thing is that they can learn from each other. Internet administered CBT is now coming to the people's help. It has been proved to be as effective as in-person therapy, and typically important in patients to maintain recovery and address triggers emotionally, immediately. I will skip through these slides as I have only 2 minutes. So how to measure the outcomes in the treatment? First, we have to consider reduction in hypersexual behavior, such as fewer compulsive sexual thoughts, urges, and actions, improvement in overall psychiatric well-being, including mood stability and anxiety reduction, improvement in individuals' quality of life, particularly in their relationships, work, and social interactions. Relapse rates are tracked over time to determine how well the individuals maintain their recovery. Role of support system is very much important, because as I said, there are very much chances of the relapse, and family members, peer support groups, and therapist or the accountability partner can play a major role in preventing the relapse and staying patient away from this hypersexual behavior. There is need for the future research in hypersexuality. Longitudinal studies are needed to track the progression of hypersexuality behavior over time and evaluate the long-term effectiveness of various treatment modalities. Refining diagnostic criteria is very much important, and the work is going on for that. Understanding the genetic and neurobiological factors underlying hypersexuality will definitely help us to develop the targeted treatments, specifically pharmacotherapy. Then exploring the role of cultural influence on sexual behavior is very much important, because what is considered hypersexual in Indian context may not be valid in Western culture. And vice versa. So the cultural influences should be learned, and this need to be studied. We have to look for the some ethical challenges. First thing is patient's confidentiality is important, but we have to report illegal activities if necessary. Clinicians must approach treatment. Just 2 slides. Clinicians must approach treatment with non-judgmental empathy. Informed consent is very much critical, specifically when we are going to start anti-androgens that can affect sexual function. Therapies must also maintain professional boundaries. As I said, these are hypersexual patients. They can try. There can be transference in the patients, and they can try to indulge in sexual behavior with a therapist also. So one should be aware of these professional boundaries. So what are the challenges? The treating hypersexuality presents several challenges. Stigma, shame, and denial from the patient is the most important. So we have to go to the community. We need to do awareness. Diagnosing the condition can be difficult, so we have to learn about the diagnostic criteria. Some of the clinicians may lack specialized training in sexual disorder, and they can have their personal attitudes which can impair the treatment as such. By addressing these challenges, clinicians can help individuals regain control of their sexual behavior and improve the quality of their life. So in conclusion, hypersexuality is a complex disorder with both psychological and neurobiological components. Effective treatment requires a combination of psychotherapy, pharmacological intervention, and support systems. Looking ahead, more research is needed to refine diagnostic criteria, explore neurobiological mechanism, and develop culturally tailored treatment approaches. As clinicians, we must continue to reduce stigma and provide comprehensive care that addresses the psychosocial aspects of the disorder. Thank you very much.
Thank you so much.
Thank you, Dr. Atul, for the wonderful presentation. I think we'll allow only one question because you are running short of time. If you don't have any question, we'll move on to the next topic.
Yeah, it was very elaborate discussion on the untouched topic, I suppose. So it's a good study. And thank you so much. I request our chairperson to felicitate Dr. Atul. And I request Dr. Nilima Deshpande to be on the stage.